CMS is committed to ensuring the highest level of health for the 150 million people covered by Medicare, Medicaid, the Children's Health Insurance Program, and Health Insurance Marketplace. That's why we're excited to announce the first CMS Health Equity Conference. This free conference will give you the opportunity to learn from leaders in health equity and discuss innovative solutions to advance health equity. Join us virtually or in person at Howard University.
Good morning, everyone. Welcome to, good morning. Welcome to our inaugural Health Equity Conference. It is a great honor and privilege for me to begin this conference and to welcome those of you who are here in person and for those who are joining us online today. My name is Dr. LaShawn McKeever, and for the last 3 years, I've had the honor of leading the Office of Minority Health at CMS. And I'm delighted to be your host over the next 2 days for our conference. The CMS Office of Minority Health serves as the principal advisor to the agency on the needs of people from minority populations, including people from racial and ethnic communities, people with disabilities, members of the lesbian, gay, bisexual, and transgender community, individuals with limited English proficiency, and rural and geographically isolated communities. We also serve as the subject matter expertise to CMS on minority health and health disparity issues, and we give recommendations on how to address them. Our office is consistently looking for ways to help all people reach their highest level of health and eliminate disparities, and we're always looking ahead. Our conference theme is Framing the Future of Equitable Healthcare. Over the course of the next 2 days, you will hear from prominent public health leaders representing various parts of the healthcare ecosystem on social drivers, influencing health outcomes, and understanding the challenges we all are facing to ensure people achieve their highest level of health. We'll discuss where we've been, and we'll discuss where we're going. We'll hear about groundbreaking ideas and new hope and direction to lead us forward. But we must take some time today to also reflect on the historic challenges that so many face in this nation. With the pandemic ending, I want to take a pause as a collective community and reflect on the journey that has brought us here today. Those of us gathered here today, again in person and online, know the disparities exacerbated by COVID-19 pandemic only brought to the forefront the long-standing disparities, structural barriers, and challenges creating real and heartbreaking disparities across the healthcare system. I will also take a moment to say thank you to those in the office, in the audience, as I know many of you were at the forefront of the COVID-19 pandemic. It was hard work, but we have worked together to get through it. Addressing disparities is hard work, and we will work together to move the healthcare system forward. We are at a historic time for health equity. It is the topic and term everyone is talking about, and I'm thrilled that at our inaugural conference today, we can bring the health equity community together at this point in history. Together, we can continue to craft our roles in working towards health equity. And the meeting today is anchored in the CMS Health Equity Framework and the 5 priority areas that you'll be hearing about over the next 2 days. It serves as an anchoring point for the work ahead. This administration has requested a whole government approach to health equity, and I am truly honored today to say that CMS is leading the way in the healthcare system. So with that, we have a packed agenda for the next 2 days, and we will now transition into our first session. It is a great honor for me to introduce our first speaker, Administrator Chiquita Brooks LaSure. Administrator Chiquita Brooks LaSure serves as the CMS Administrator for the Centers of Medicare and Medicaid Services, where she oversees programs including Medicare, Medicaid, the Children's Health Insurance Program, and the Healthcare.gov Health Insurance Marketplace. A former policy official who played a key role in guiding the Affordable Care Act through passage to implementation, Administrator Brooks LaSure has decades of experience in federal government, on Capitol Hill, and in the private sector. Administrator Brooks LaSure began her career as a program examiner and lead Medicaid analyst for the Office of Management and Budget, coordinating Medicaid policy development for the Health Financing Branch. It is my sincere privilege to welcome to the podium at this time Administrator Chiquita Brooks LaSure. Thank you.
Good morning, everyone. Let me start by, as LaShawn said, thanking you all for joining us. And let me also say just a huge thank you to Dr. McGeever for, as well as her office, for the vision of putting together this conference. And just a delight it is to see all of you, whether here with us or virtually. I also want to thank our federal partners who have joined us this morning, just so that you can see how much this is a whole of government approach. I just want to say, on the heels of the pandemic, we know that it's critical that we continue to work together towards that same point on the horizon to build back a better healthcare system that puts people at the center of their care. Your leadership and commitment to advancing health equity is really essential to turning our discourse on health equity into tangible change. I like to say, I don't want this to be a moment of time where we talk about health equity and then 10 years later we've moved on to a new topic. Let this be the continued effort that we all need to see to sustain change. Across the 3 M's in CMS, Medicare, Medicaid, and CHIP in the marketplaces, CMS now oversees almost 1 in 2 Americans in this country. Our record numbers, the numbers keep increasing in a positive way, more than 150 in the video, more than 160 in some of our talking points, and now we are at over 170 million people who are covered by our programs. It is critical that people who are covered by our programs be the focal point of everything we do. CMS is working hard every day to ensure that the people we serve can get healthy and stay safe, regardless of what they look like, where they live, how much money they make, or other factors. CMS programs are powerful tools to improve the lives of Americans, including people in underserved communities. Enrollment in health care coverage is the foundation of addressing health inequities. It is necessary, but not sufficient, to make sure people can get the care that they need for their health care issues. It's also critical that they can get the preventative care before other issues arise. Advancing health equity we're really trying to make sure it's a cornerstone to all of our programs. We've made incredible strides over the last 2 years, especially in expanding access to healthcare coverage. Thanks to the investments of the Biden-Harris administration, we have the lowest uninsured rate in history. It is one of our top priorities to keep people connected to healthcare coverage, especially as states begin unwinding the Medicaid and CHIP continuous enrollment that kept people covered during the COVID-19 public health emergency. We are doing everything in our power to ensure people know the steps they need to take to maintain coverage, or where to turn next if they are no longer eligible for Medicaid and CHIP. It's an all-hands-on-deck moment. We're collaborating closely with states, other federal agencies, and community partners. You'll find our guidance and toolkits on Medicaid unwinding at our website, medicaid.gov/unwinding. Alongside our historic gains in enrollment, we're advancing equity across all of our programs. We recently shared a new fact sheet outlining our accomplishments over the past year. It's on our website if you haven't seen it yet. You'll see in that fact sheet, when it comes to health equity, CMS is pulling all of our levers to dismantle barriers and bridge disparities in healthcare. Levers like marketplace enrollment, ACO REACH, and the birthing-friendly hospital designation, just to name a few. All of you contributed to pulling these levers, and I'm proud of what we have accomplished together, and I'm excited for the road ahead. Among our biggest levers are the Medicaid and CHIP programs, which serve more than 92 million people. That's more than 1 in 5 Americans, many in underserved communities. Thanks to Medicaid and CHIP, they can get high-quality health care at virtually no cost. And today, we're helping you see the people in Medicaid and CHIP. We just released, for the first time ever, data briefs that describe the social and demographic characteristics of the people we serve in Medicaid and CHIP. The new brief provides information about race and ethnicity, rural residency, primary language, and disability-related eligibility data. We're committed to identifying disparities in healthcare and making focused, evidence-based investments to improve health equity. The information released today are a critical part of our strategy. Kimberly Proctor will be speaking about the data in more detail during the conference, and we look forward to hearing your feedback on it. Before I close, I'd also like to mention our new forthcoming diabetes strategy, which we are also pre-reviewing during this conference. Bill Mayer will be sharing the details tomorrow. Our action plan was developed as part of the White House strategy on hunger, nutrition, and health. As always, we are very interested in hearing your feedback. It is that feedback that strengthens our programs and accelerates our drive towards equity. Engaging with all of you is as fundamental to our mission as expanding access and driving innovation. We want to make sure that our work together is a dialogue and bi-directional. We not only want to make sure we're listening to our stakeholders, but incorporating your perspectives into our implementation. Thank you again for being here today, and please enjoy the rest of the conference.
Administrator Brooks LaShore, thank you for your leadership efforts on health equity and for taking your time to join us today. So you'll hear me say again and again that we cannot achieve health equity alone, and it takes each one of us here in this room today and those who are joining us online to do this important work. So we are glad that you took your time to join us today at our conference as we look to advance health equity. At this time, I'd like to ask you to turn your attention to a brief video.
We have to think holistically about what's happening in our healthcare of the country and how that can affect us. And so that's what we're trying to address, of the inconsistencies across our healthcare system. Some of it is a result of years and years of systems operating the way they have. It's incredibly important for us as an agency to lead the way, because our programs are incredibly important to the healthcare industry as a whole. It is critical that health equity be at the core of all of the work that we are doing. We cannot achieve our goals until everyone attains their highest level of health. I think it's critical that we make sure we use this moment and that it's not just a blip, as often it can be. We make sure that we develop relationships that are sustainable and policies that are sustainable.
The reason that it's so important for us to focus on designing systems, economic systems, health systems, in a way that center the needs of women and families of color is because when you design for the more challenging cases, the system is better for everyone. And especially something that's very important when it comes to addressing bias in healthcare was to draft and pass and get included Section 1557 of the ACA. And Section 1557 is also known as like the anti-discrimination part of the ACA. There is no moral justification for discrimination. And we need to remedy that. And we can do it.
Advancing health equity can be difficult. The things that we're facing have been generations in the making. However, we can't give up. There's someone that needs the care that we're responsible for delivering as the largest health insurer in the country. And so although sometimes it's challenging to advance health equity, when we do it together, we can get more done. And that's, again, why having people come together, share their thoughts, their ideas, the progress they're making, the lessons that they're learning, it allows us all to get there together. Okay, I hope you're sensing the theme together. Okay, I am now privileged to introduce our next speaker, Assistant Secretary for Health at the U.S. Department of Health and Human Services. Admiral Rachel Levine serves as the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Commissioned Service Corps. She fights every day to improve health and well-being of all Americans. Admiral Levine's storied career, first as a physician in academic medicine focused on the intersection between mental and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, she addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. I'm so glad we will be able to hear from Admiral Levine today. As I understand, she'll be able to share some vital topics related to health equity. Thank you.
Well, good morning. Thank you for that introduction. I am truly honored to join you here today at Howard University for the inaugural CMS Health Equity Conference. Today, I would like to discuss some of the progress made and initiatives undertaken by our department to promote health equity, reduce disparities, and ensure equitable access to healthcare services across the country. In my role as the Assistant Secretary for Health, I oversee a number of program offices, and they include the Office on Women's Health, the Office of Minority Health, the Office of Infectious Disease and HIV/AIDS Policy, among others. Each day, we strive to address the diverse public health needs of our nation, and our goal is to achieve our vision of healthy people, healthy communities, and a healthy nation for all. Achieving health equity requires valuing everyone equally, with focused and ongoing societal efforts to address avoidable inequalities, historic and contemporary injustices, and of course the social determinants of health, and to eliminate disparities in health and health care. Everything we do at the department under Secretary Becerra's leadership emphasizes health equity. Individualized factors such as climate change, long COVID, and LGBTQI+ health equity have a profound impact upon the health and well-being of our nation. They are crucial roles in our policy priority areas. So today I will highlight the steps we are taking at the U.S. Department of Health and Human Services to promote health equity in these priority areas as we focus on framing the future of equity in healthcare. As we celebrate Pride this month, or what I fondly refer to as a summer of pride, I want to take a moment to highlight the significant strides that we have made in advancing LGBTQI+ health equity and the challenges ahead. My office is leading key HHS policy initiatives to advance health and well-being for LGBTQI+ people living in America. We are working to implement President Biden's national HIV/AIDS strategy, working to safeguard LGBTQI+ youth from the harms of conversion therapy, and addressing health disparities head-on. This Pride Month and this Pride Summer is an opportunity to catalyze change. Change for our communities, change for our states, and change across the nation, so this really will be a summer of pride. I also want to encourage you to prioritize your own health with tangible actions such as quitting smoking, getting an HIV test, or routine cancer screening. And please, if you are at risk and you are not yet vaccinated for Mpox, please get vaccinated with 2 doses. Healthy People 2030 defines health equity as the attainment of the highest levels of health for all people. For all people. And I have said many times, I firmly believe that we have not truly made progress unless we have all made progress. I do want to acknowledge that this has been a particularly difficult year for transgender people and trans youth in particular, and their families and their providers. These political and ideological attacks in numerous states are not grounded in science or evidence. Gender-affirming care is essential health care. Gender-affirming care is mental health care. Gender-affirming care is quite literally suicide prevention care. It is based upon decades of study, and it is an evidence-based standard of care. Based upon this history of research and medical evidence, the overwhelming majority of professional medical organizations endorse transgender medicine or gender-affirming care where it is medically necessary, safe, and effective for transgender and non-binary youth and adolescents. Achieving health equity requires valuing everyone, which means making focus and ongoing efforts to end inequalities, eliminate the impacts of injustice, and improve the health for everyone. We have to take a stand. We have to take a stand of those who are being hurt by these ideological and political attacks. Thank you. Those who attack our LGBTQI+ community are driven by an agenda that has nothing to do with science. It has nothing to do with medicine, and it certainly has nothing to do with compassion. The political and ideological attacks on trans youth are contrary to the overwhelming science and evidence that supports the WPATH standards of care that were written just last September 2022 in their update. So it is our responsibility to take a firm stance in support of those who are being harmed. If someone needs a friend, an ally, or simply a supportive individual to advocate them, you have the power to be that person. In fact, research from the Trevor Project shows that LGBTQ youth experience significantly lower rates of suicide attempts if they have one supportive adult. One supportive adult. That's what it takes to save a life. Now, one of the most pressing threats that we face every day, and you can see the impacts looking right outside our door from fires in Canada, is climate change, which poses a significant risk to the health of people in the United States and throughout the world. Climate change continues to exacerbate severe weather events, such as extreme heat, flooding, wildfires, and it worsens physical and mental health stressors, such as poverty, chronic stress, and asthma. Unfortunately, those same communities most impacted by climate change are those same communities that face economic and social marginalization in our country. This makes it even more difficult for those communities to prepare for, respond to, and recover from the hazards associated with climate change. This includes, of course, individuals who belong to communities of color, indigenous populations, those with low income, older adults, children, rural communities, people with limited access to health care, and those with underlying health conditions. Historically, these communities have struggled with greater exposure to extreme heat and to pollution, exposure to and lack of preparedness for extreme weather events, and other environmental injustices, such as decreased access to clean air, safe drinking water, nutritious food, and safe shelter. So to address these long-standing environmental injustices and inequities, the Biden-Harris administration is taking decisive action to make a positive impact on people's lives now and in the future. Within HHS, we have established 2 new offices that report to me. Our Office of Climate Change and Health Equity. Now notice it's not an Office of Climate Change and Health. It emphasizes the health equity component. And our Office of Environmental Justice. We are proud to coordinate and collaborate across our colleagues at HHS and other offices like ACF, across HHS and the federal government, and wherever environmentally challenged communities exist. Through OCHE, we affectionately call our Office in Climate Change and Health Equity OCHE, everything has to have an acronym. We continue to raise awareness about the threats that climate change presents to public health and share resources for care providers to accelerate their work on preparedness and mitigation. We understand that the intersection of climate change, health equity, economic justice, and environmental justice are critical, and we are committed to shaping a healthier and more equitable future that accounts for those intersections. I want to highlight our efforts regarding long COVID and our efforts to develop an equitable response for preventing, detecting, and treating long COVID. This was highlighted in the COVID-19 Health Equity Task Force. As our nation continues to make strides in combating COVID-19 and ending the public health emergency, it is crucial that we deal and address the impacts of long COVID and provide resources to those in need. Estimates vary, but anywhere between 7.7 and 23 million Americans have developed long COVID. So we need to educate the public and combat misinformation surrounding this condition, which presents challenges in communications with the public, with patients, and even within our healthcare community. Long COVID is real. Long COVID is real, but it might not be one condition. It might be a set of infection-associated conditions that represent potentially overlapping entities, potentially with different biological causes, different sets of risk factors and outcomes. So more research and more resources will be needed to help us stay prepared for long COVID's longer-term impacts. Now, again, long COVID is also another health equity issue, and I mean that on multiple fronts. Patients may find difficulties getting effective treatment, navigating health-related workplace and employment issues, and finding understanding among their peers and even the medical community about their condition. This is particularly true with those with limited resources, and they certainly impact the quality of life of those patients and their families. My office will continue to coordinate and support the research across the Department of HHS and across the administration. We are forming our new Office of Long COVID Research and Practice, and we have heard from people living with long COVID, their families, healthcare workers, and researchers about the obstacles that they face, including providers who dismiss long COVID patients, patients who wait long times to see specialists, and communities and whole areas that have limited treatment options for the diverse and complicated array of symptoms. Many people that we have spoken with have implored us to do more to start to translating research into therapeutics, and we have heard them. We understand that patients need timely help and direct, culturally competent pathways to remission or recovery. While there is still much to learn, foundational research is already providing valuable insights and informing the development of long COVID clinical trials, which will start in 2023. These will help find treatments to help relieve the most challenging and burdensome symptoms of long COVID. Our driving focus is to ensure, again, that long COVID is real and help people recognize that if they have long COVID and the symptoms of long COVID, to help them get the care and the support that they need as soon as possible. So we are going to continue to address the needs of the long COVID community and collaborate with patients, states, industry partners, and advocates to fulfill our commitment to protecting public health and well-being. And while we have made progress in the fight against long COVID, our work is far from over. In fact, it's really just beginning. and we remain dedicated to advancing our understanding and to providing effective solutions for those harmed by this condition. So before I conclude, I want to talk about another health equity issue, which is very important, and very important to Secretary Becerra and myself and many at HHS, and that is sickle cell disease. Sickle cell disease is one of the primary chronic diseases that disproportionately impacts people of color, and who often face challenges in accessing quality and affordable care, both for acute and chronic treatment of sickle cell disease. So at HHS, we are working across the department to improve outcomes and address the health disparities faced by individuals and families impacted by sickle cell disease through collaborative efforts, data collection, and targeted initiatives. To effectively address sickle cell disease, we recognize the importance of data. Data serves as a powerful tool. Data actually tells stories. It aids in program planning, shapes policies, promotes education, and we want to support advocacy efforts. Data also plays a crucial role in raising awareness among communities and helping clinicians identify patients that need sickle cell treatment. Data should reflect the diversity of our culture and conditions. It needs to consider race, ethnicity, gender, age, and more. And the lack of diversity among research data sets can have serious implications and consequences on research, program, and policy. So at HHS, we're working with leaders across the department and with community partners to prioritize and modernize the sickle cell data system. The CDC has done significant surveillance work with their sickle cell data collection program. The SCDC program collects health information about people with sickle cell disease to study long-term trends in diagnosis, treatment, and healthcare access for people with sickle cell disease in the United States. In addition to our work with the CDC, our colleagues at HRSA fund HRSA's sickle cell disease programs, and they have a national reach with 91 sites and grantees throughout the country. These programs support data collection through various initiatives, including the newborn screening program, of course, the federally qualified health centers, and other sites such as the Sickle Cell Disease Treatment Demonstration Program centers. The data from these programs collectively strengthen the sickle cell disease system of care and support for patients with sickle cell disease and their families. It educates patients, families, and clinicians to improve knowledge and to improve capabilities. They also link individuals and families to evidence-based care and foster partnerships between clinicians, community organizations, and other stakeholders to enhance the delivery of coordinated, comprehensive care for sickle cell disease across the lifespan. So in closing, despite the challenges that we face, I remain a positive and optimistic person. I choose to remain positive and optimistic in the face of these inequities and these challenges. And I believe that working together, by working all together, we can create a better future for all people living in the United States. COVID-19 and the challenges of the past 3 years have reminded us of a fundamental truth, that we truly need each other. Our happiness and our very survival depends upon our connections to one another and to our communities. And that spirit of community is what makes our country great, and is what we need now more than ever. We know that there are many groups that face unique and increased risks. We must close disparities in access and outcome, eliminate bias and discrimination, and address the systemic barriers, including the barrier of systemic racism, that have contributed to historic inequities. All Americans deserve health care and public health services that are timely, affordable, accessible, equitable, and high quality. These are people that you know. They are our family members, our friends, our neighbors, students, coworkers, and community members, and we are truly all in this together. Through our collective expertise and collaboration, we will pave the way for a future where equity in healthcare is a reality for all individuals and all families and all communities, regardless of their backgrounds or circumstances. Thank you all for doing everything that you can to support healthy people, healthy communities, and a healthy nation for all. Thank you very much.
Wow, what a way to start our conference. Thank you so much, Admiral Levine, for those remarks. So as we will be gathering here over the next 2 days. We'll examine some of the historical things that have impacted health equity, and Dr. Levine talked about that in her remarks. Where we've been and where we stand today. We'll consider the intersection of these factors and consider our achievements and lessons learned so we can build towards a future of health equity. She talked about history in her remarks. We cannot ignore history and an individual's historical experience and the impact that has had on their health. We all are familiar with social determinants and drivers of health, and we hope to keep those factors at the forefront as you experience the conference today. As you consider this, consider the individual, community, and structural barriers some may experience, and the different types of disparities that different communities face. We now actually have one of our speakers is going to join us earlier on the agenda. Before we go any further, we're going to acknowledge this amazing and beautiful campus that we're on today. When we began planning, our team thought about Howard as a possible host for our conference, and now it is a reality, and we could not be more excited. So we would like to thank the Howard community for welcoming the Centers of Medicare and Medicaid Services and the health equity community to the conference, to your space for our conference today. Our office is always looking for ways to involve and include minority-serving institutions like Howard University. And we even have a grant program, the Minority Research Grant Program, to support researchers at minority-serving institutions, which, by the way, has an open notice of grant funding posted on grants.gov. And it's open for 1 more month, so I encourage you to go to that website. To host our conference here, though, at Howard University is really helping us to demonstrate our commitment to every level of healthcare partner. Student, researcher, provider, and community partner, all of which is seen here at Howard. Thank you. So now it is my pleasure to introduce Dr. Andrea Hayes Dixon, who is the first African-American woman to lead the College of Medicine here at Howard. Dr. Hayes Dixon is the professor and chair of surgery at Howard University College of Medicine. She's also the associate director of the Cancer Center at Howard. In October of 2022, she was appointed to the position of Dean of Howard University's College of Medicine and Vice President of Clinical Affairs. Dr. Hayes Dixon is the first African-American female pediatric surgeon in the USA and is the first, yes, that's amazing. And as noted, is the first female dean of Howard University's College of Medicine. She is nationally and internationally known for her work, and we are excited to have her join us today. Dr. Hayes Dixon. Thank you so much, Dr. MacGyver, for that wonderful introduction, and welcome to Howard University's campus. We are so pleased and excited to have you here, and congratulations on your inaugural Health Equity Conference. I think it's apropos for you to be here at Howard because in our 155-year history, we have supported our community, and health equity is at the forefront of that support. In addition to my responsibilities in the College of Medicine, I support the other health sciences such as the College of Dentistry, the Howard University Hospital, the College of Pharmacy, and the Allied Health and Wellness. In those areas, we always, of course, have students that we're educating. And those students are educated on 4 pillars. The first pillar is education, the second is clinical care, the third is research, and the fourth is community. I'll emphasize community today in saying that is a critical reason why the students here come here to learn. They learn how to take care of patients in settings where the community looks like them. I know many of you may not be familiar with the makeup of Washington, D.C. and the community here, but in Washington, D.C. and some of the boroughs and areas, we have up to 60% of the population that are underrepresented minorities. We have a rainbow of the African diaspora here in Washington, D.C. The patients we see and the students meet to educate are primarily from African American, Afro-Caribbean, first-generation African, including Ethiopian and Kenyan and Nigerian backgrounds, as well as Latino backgrounds. This gives them a unique opportunity to embed themselves into the community and understand the community's needs. Them understanding the needs of the community allows them to be able to think about how to eliminate disparities and how to provide health equity. Providing health equity in this environment is challenging. It's challenging because we have a problem with access to care, which we need to encourage our students to work on. Access to care is the first portion of health equity. If you cannot get access to care, you cannot have equitable health care. The Association of Graduate Medical Education has identified that students who graduate from medical school who are either African American or Latino or have an 80% chance of going back to the communities that look like them to practice compared to their non-African American and non-Latino American counterparts. That means that the large communities that we serve that require this care need more physicians to do this, need more nurses, need more pharmacists, need more dentists in these communities. That is the challenge that we face. The opportunity we have here at Howard is to use our faculty members and our students to educate them in that area of health equity. Another study from the New England Journal of Medicine cites that if an African American doctor treats an African American patient, that patient is much more likely to live longer, as much as 2 years longer than if they had been treated by a non-African American provider. That article just came out several months ago, and it really challenges us to match patients with the providers they feel more comfortable with so that they're more likely to take advice from their doctors. That's our responsibility. Here at Howard, one of our researchers, Dr. Kakra Hughes, looked into the area of amputations and vascular access. So in patients with diabetes and hypertension, and some of them that have vascular disease, they have hardening of the arteries and they develop sores on their feet. And the vascular surgeon is faced with the decision of whether to amputate that person's foot or whether to revascularize or kind of redo the plumbing, if you will, in their legs in order to restore health to their feet. Dr. Hughes studied the entire country and understood from that when doctors are faced with this decision, if the patient is either African American or Latino, that individual is more likely to be offered an amputation as opposed to a revascularization. And that is a health disparity, just one of the many health disparities that we are forced to address. Why is it that patient X is told they need an amputation and patient Y is told they need to save their leg? We really have to understand the dynamics of our communities, of our faculty, and use this opportunities to educate our students as to how they should treat patients equitably. And it's not only the physicians that are responsible, and it's also everyone around us, the community, and people like yourselves who are having this conference. I really want to thank you for having this conference. I looked at the posters that you all will be looking at later, and I'm excited about all the research that's being done. I need you to know that health equity is at the forefront of what we teach here at Howard, and I thank you again for choosing to have this meeting on this campus, and again, welcome. Thank you for those remarks. Now I'm going to introduce our next speaker, Benjamin Smith, the Deputy Director at the Indian Health Service. Benjamin Smith, an enrolled member of the Navajo Nation, is Deputy Director for Indian Health Service. The IHS, an agency within the Department of Health and Human Services, is the principal federal healthcare provider and health advocate for American Indians and Alaska Natives. As deputy, Mr. Smith leads IHS operations to ensure the delivery of quality, comprehensive health services, and that IHS services are integrated across all levels of the agency. The IHS Deputy Director facilitates collaboration between IHS and tribes to increase access to quality healthcare programs and assists with the development of standardized metrics and monitoring progress of goals to ensure that the quality standards are being achieved throughout the Indian health system. Mr. Smith also ensures IHS services are integrated across all levels of the agency and engage with other operating divisions of the Department of Health and Human Services and external partners, including states and national organizations. Mr. Smith, thank you.
Yes, good morning, everybody, and thank you so much, Dean Dixon, for the welcome to Howard University. I think this is such an excellent place for today's event as we are all learning together. I also want to thank CMS for putting together this very informative, creative, and exciting event, and for inviting the Indian Health Service to be with you today to discuss health equity in American Indian and Alaska Native communities in particular. I'm truly honored to join this distinguished panel of speakers. This collaboration on health equity, as reflected by the wide representation of agencies and organizations in this room, hits on an important priority at the Indian Health Service, specifically to advance our mission, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. Many of you might not be familiar with the Indian Health Service, so I do want to spend a little bit of time to provide some background on what we do as a federal agency. The Indian Health Service is an agency within the U.S. Department of Health and Human Services that provides health care to approximately 2.7 million American Indians and Alaska Natives, who are members of 574 federally recognized tribes throughout the country. Our network consists of approximately 605 hospitals, clinics, and health stations that are either on or near an Indian reservation. In addition to those facilities, we also have 41 urban Indian organizations that are placed throughout metropolitan areas throughout the country. The provision of health services to members of federally recognized tribes grew out of a special government-to-government relationship between the federal government and each Indian tribe. This relationship was formally established in 1787, and it's in the U.S. Constitution at Article 1, Section 8. And this relationship has been given form and substance over time through numerous treaties, laws, court decisions, and most recently, executive orders. I want to underscore that the U.S. government's commitment to providing access to health care as established in these treaties and the laws is a responsibility of the entire U.S. government. It's not just the Indian Health Service. We all have a role to play. We are the main embodiment of that obligation, but across the country, every part of the government is also responsible, and we expect them to play their role. Today, the Indian Health Service staff consists of more than 15,000 employees nationwide, including healthcare providers like doctors, nurses, dentists, pharmacists, dietitians, and optometrists. We also provide a comprehensive environmental health program that includes environmental health, injury prevention, and safe drinking water and solid waste sanitation facility construction services throughout Indian country. Our number one goal is to ensure that comprehensive, culturally acceptable, personal, and public health services are available and accessible to American Indian and Alaska Native peoples. However, at the Indian Health Service, like many of of you in the room today, the Indian Health Service faces unique challenges in providing health care to American Indians and Alaska Native communities, including limited funding, geographical isolation, and a higher burden of chronic diseases. To comprehend these challenges facing Native communities, it's first necessary to understand and recognize the many factors that contribute to health disparities faced by American Indian and Alaska Native peoples. These include social determinants of health such as food supply, housing, and education. All of these affect health, as well as the impact of colonization, historical trauma, and forced relocation that continue to resonate in tribal communities even today. While we've made significant strides in improving health care access and outcomes, health disparities persist among Native populations. Ongoing efforts continue to focus on addressing the social determinants of health, supporting community-led initiatives, and ensuring equitable access to quality health care for American Indian and Alaska Native communities. We know that health starts in our families, in our schools, in our workplaces, and in the air we breathe and the water that we drink. The Indian Health Service initiatives are intended to achieve health equity. These include efforts such as expanding healthcare coverage, increasing funding for Indian Health Service facilities, promoting culturally competent care, and supporting community-led programs. However, achieving health equity requires sustained commitment and collaboration between tribal communities, government agencies, and healthcare providers to address the systemic and social determinants of health that impact American Indian communities. Partnerships is absolutely essential. To improve the social determinants of health, an important part is, and this is such an important part of the Indian Health Service mission, which requires us to partner with all of you here, with the 574 federally recognized tribes across the country, those urban Indian organizations that are serving members of American Indians and Alaska Native tribes throughout the country, nonprofit organizations, academic institutions, you name it, it goes on and on. In fact, for example, currently the Indian Health Service has partnered with the U.S. Department of Veterans Affairs to work closely to improve the health status of American Indians and Alaska Native veterans. We are advancing collaboration, coordination, and resource sharing between the VA and the IHS to ensure equitable access to care and services to American Indian and Alaska Native veterans. We are also committed to working with academic partners like the Johns Hopkins Center for American Indian Health. Our partnership with Johns Hopkins started 30 years ago when we signed our first Memorandum of Understanding when the Center for American Indian Health was founded. And it has been consistently reviewed and updated by every IHS director and acting director since that time. Key areas of this type of collaboration include expansion of workforce development for American Indian and Alaska Natives by, one, providing educational opportunities in allied healthcare, health sciences, graduate and doctorate level students. Two, specialty training for community health paraprofessionals to assist with promoting physical, behavioral, and mental health and well-being. And finally, our continued work with tribal and urban Indian communities to disseminate and implement evidence-based practices and promote behavioral and mental health and well-being. A particular focus of our current Memorandum of Understanding with Johns Hopkins is on designing sustainable interventions that can be administered by available mid-level or community health workers, such as community health aides, public health nurses, community health representatives, and others. We're looking to expand these types of relationships with other academic institutions and organizations across the country. And we have other federal and national partners, including the Boys and Girls Club of America, the American Dental Association, the Department of the Interior, organizations like the National Congress of American Indians and the National Indian Health Board, along with many, many more in the sectors of health, medical, and local organizations assisting us. All of these partnerships have been established to complement health programs and to examine how improvements in education, law enforcement, business practices, and employment can have positive effects on health status. We've also partnered with a number of national universities for fellowships, residencies, and clinical rotations to bring talented new practitioners into our facilities and introduce them to our mission at the Indian Health Service. These opportunities provide excellent clinical and cultural experiences with Native communities and can lay the foundation for a fulfilling career in Indian health. This not only provides short-term staffing, but serves as a long-term recruitment tool, with many returning to practice later in their careers. The future of health equity is upon us. We've heard from dynamic presenters earlier today, and that effort holds great potential for positive change. I really invite each of you to think about that. You are each change agents and play a role in helping us achieve the goals of health equity. The future of health equity care lies in a comprehensive and multifaceted approach that addresses the social, economic, and cultural determinants of health. By prioritizing these aspects and ensuring equitable access to quality care, we can work towards a future when everyone has an equal opportunity to achieve optimal health and well-being. I hope this snapshot of the American Indian and Alaska Native sector within our community here in the U.S. as a whole is helpful. And we look forward to working with you along this path, along this mission, and efforts to achieve health equity. Thank you.
Thank you, Mr. Smith, for your remarks. So we're going to pause to just share a few logistics before we move into the next part of the plenary. The conference website has all the information that you'll need related to the conference, so the agenda, the breakout session topics, and the locations, as well as off-site lunch options. We are about to move into the opening of the Federal Partner Showcase poster hall and breakout sessions. The Federal Partner Showcase is in the back of the ballroom here. It will feature agencies across the federal government that are working to address social determinants of health. The poster hall can be found right outside the ballroom in the hallway. And for those attending virtually, the Posters and Partners tab on the top of the page allows you to see the PDF versions of the posters and information about our federal partners. Breakout sessions will begin at 10:45. The following breakout rooms are located on the first floor of the building: the Blackburn Forum, the Blackburn Digital Auditorium, the Reading Lounge. Breakout sessions are located in the Recreation Room, which is on the lower level. Also, there is a lactation nursing room located on the lower level. Please look for signage outside of the door for the name of the room. If you included your lunch order in your registration, please proceed to the lower level where you can pay for your order with a credit card and pick up your lunch order. If you did not register for lunch, the website lists options that are close to campus. Feel free to eat and network with this great gathering of health equity champions, and we will see everyone back here at 1:45 for the OMH Directors Panel, followed by the CMS Maternal Health Strategy and closing. Now, our final plenary speaker for the morning is President Biden's appointed Senior Advisor and Director of the Office of Public Engagement, Mayor Stephen Benjamin. This position ensures that community leaders, diverse perspectives, and new voices at local, state, and the national level have the opportunity to inform the work of the Biden-Harris administration in an inclusive, transparent, and responsible way. Steve Benjamin served as mayor of Columbia, South Carolina from 2010 to 2021. He served as the 76th president of the U.S. Conference of Mayors from 2018 to 2019, and as president of the African American Mayors Association from 2025 to 2016. He currently serves as the president and CEO of the Benjamin Firm. Benjamin also has been executive chairman of Municipal Bonds for America, a member of the Federal Communications Commission's Intergovernmental Advisory Committee, and a member of the Accelerator for America Advisory Council. Prior to his service as mayor, He served in the South Carolina governor's cabinet as a chief executive of the state's second largest law enforcement agency, the Department of Probation, Parole, and Pardon Services. He is awarded the U.S. Small Business Administration's 2017 Phoenix Award for Outstanding Contribution to Disaster Recovery by a public official for his leadership during an October 2015 flood. We are delighted to have him join us this morning to share remarks on the importance of stakeholder engagement in the equity space.
When you walk in and go straight to the stage, okay? So, some of you may know, obviously, I'm a former elected official, so people often think that you're used to, you enjoy public speaking. I served for office for 12 years, 3 years in the governor's cabinet. I've never enjoyed public speaking. And oftentimes I get to speak, I think of the first time I spoke at my home church, the St. John Baptist Church in Columbia, South Carolina, and I was done. A little guy came up to me, he said, "Now grow up, I'm gonna give you some money." I said, "Well, thank you, son, but why?" He said, "Because my daddy said you're one of the poorest speakers we ever had." So I figured I'd get up to speak when I actually had something worth saying. It's really an honor to be here with you this morning. We thank Dr. McIver for her introduction that I did not hear because I was still not in the room yet. But thank you so much, and to Administrator Brooks Ashore, who I did have a chance to briefly meet with before we came in. So thank you for the invitation to participate in this inaugural health equity event. There's no better place than Howard University. Howard grads are so serious. So serious. We came with the president a few weeks ago for commencement, and I'm like, okay, this is a lot. This is a lot. But it's well-earned pride. There really is no better place than being here at Howard. Howard's been at the forefront of health equity long before that's what we called it. Been fighting the good fight for so long. It's wonderful to see so many of you here today. And then we also have several people participating virtually who I also want to acknowledge their presence too. It won't be before you long, but I did want to come and share today the President and Vice President's commitment to prioritizing equity and ensuring that the promise of America is attainable for every American. It is central to every single policy decision made in the White House over the last 2+ years. On his first day in office, the President signed an executive order to advance equity across all of government, and built on those actions with another executive order in February of this year. In just 2 years, President Biden and Vice President Harris have achieved several victories towards increasing health equity and well-being. On hunger and diet-related diseases, in September of last year, the President hosted the very first White House Conference on Hunger, Nutrition, and Health in over 50 years, released a national strategy, and announced over $8 billion of external commitments to achieve the goal of ending hunger and reducing diet-related diseases by 2030, all while reducing disparities. I know I'm speaking to a group that understands how important this step was and is, so let's consider a few statistics. In 2021, 1 in 10 households experienced food insecurity, meaning their access to food was limited by lack of money or other resources in the wealthiest and most powerful nation in the history of the world. Diet-related diseases are some of the leading causes of death and disability in the U.S. Data shows us that 19 states and 2 territories have an obesity prevalence at or above 35%. It's more than double the number of states from 2018. 1 in 10 Americans have diabetes. 1 in 3 people will have cancer in their lifetime, and more than 4 in 10 Americans have hypertension or high blood pressure, which is linked to the leading causes of death of Americans: heart disease and stroke. The toll of hunger and diet-related diseases is not distributed equally. These challenges are disproportionately felt in communities of color, people living in rural areas, people living in territories, people with disabilities. older adults, our LGBTQ plus community, military families, and amongst our veterans who served this country so proudly. So to continue driving progress and achieving the goal of ending hunger and reducing diet-related diseases, the administration also launched the White House Challenge to End Hunger and Build Healthy Communities in March of this year to rally a second round of public and private sector commitments. The challenge highlights priority areas under each pillar in the national strategy to fill gaps from the prior round of external commitments that will help advance this national strategy. We're looking for bold, transformative commitments that will have a sustainable impact, multi-sectoral, public, private, philanthropic partnerships that make sense. I encourage you, if you have not already, to go to whitehouse.gov/Hunger Health Conference for more information and to consider making a commitment. The due date to submit is August 18th, and the White House team is happy to connect with anyone who's interested in brainstorming or has questions about the effort. On the incredibly important issue of maternal health, the White House is also working to advance equity and eliminate these incredible disparities that exist. The Biden-Harris administration is committed to reducing the unacceptably high rate of maternal mortality for Black mothers. To that end, President Biden and Vice President Harris created the Maternal Health Blueprint, which lays out a government-wide plan to improve maternal health with an emphasis on reducing disparities while focusing on populations that suffer the worst outcomes. The president has shown his commitment by including $471 million, nearly $500 million in his proposed FY24 budget to support implementing the blueprint. The president's budget also demonstrates his resolve to advancing equity by expanding access to home care, by investing over $150 billion over 10 years in Medicaid, home and community-based services, so people with disabilities and seniors can get the care they need at home. And as I'm sure you just heard from Ms. Smith, the investing an additional $3 billion from the Indian Health Service and securing stable funding for years to come. And also, of course, facilitating access to rural healthcare facilities and increasing the rural healthcare workforce. The president intends to continue on this steady progress towards equity through furthering increasing enrollment in affordable, quality health insurance beyond the historic high of 16 million Americans who enrolled in ACA coverage for this year, leveraging Medicaid options to extend postpartum coverage to 12 months and implementing innovative approaches to addressing health-related social needs, and also coordinating a whole of government approach to reducing disparities in social determinants of health. There's a lot more that's needed, but I'm proud to be part of an administration while I'm serving under the leadership of a president and vice president who've insisted that we keep equity at the core of everything that we do. We've made strides, great strides in the last 2 years, but we need your help and your partnership so that we can, as the president says, finish the job on health equity. I hope you enjoy the remainder of the conference today and tomorrow, and I hope that each and every one of you takes a little bit of time to appreciate the role that you play at this critical moment in world history. We are indeed the essential nation, and other nations watch everything that we do here and the commitments that we make to all of our citizens, including those who may be considered the least among us. You're doing the most important work, and I want you to know that the President and Vice President are very thankful for your leadership. May God bless you and keep you. Thank you.
Thank you, Mayor Benjamin, for those remarks. I hope you are energized and excited for the remainder of the conference. We had one hand clap. Again, we are so delighted that you could join us today. This marks the end of the plenary for this morning. We shared the logistics of where you're headed to next, and we will reconvene here at 1:45. Thank you all so much.